So welcome everyone to this session. So this session is named Angiography-based FFR. So it's a sponsored session by Pi Medical and Siemens. So I guess that everyone here in this room is familiar with the FFR, so with the use of the wire. And if you are here, is because you want to increase your knowledge about what is called angio-based FFR. And actually, I must say that you are in the right room for increasing actually your knowledge. We have prepared a very interesting session. So, and you will see what is the clinical evidence behind the use of angio-based FFR. So you will see how to identify the best patient for using this kind of technology. And then we have prepared a very interesting tutorial about step by step, how to use the software and how to make your measurement. I'm Salvatore Brugaletta, and I'm an interventional cardiologist from Spain, and I have the pleasure to be here together with Ziad Ali, who will be our spokesperson. And Ziad will explain you how to make the interaction with you, how to ask questions.
Great. So you're obviously here because you either hate wires or adenosine or love angiograms, or you like lunch. But I think the focus on this session is over the last several years, we've been talking a lot more and more about angiography-based FFR. And it's been an iteration of technology where we need to get to the point where it's really utilitarian. And what we'd like to do is have audience participation about what are some of the barriers. Do you believe that the clinical evidence is enough in the current situation? What are the practical aspects that are limiting people from using it? What's the availability like? And any other questions that you may come up with. You can use the app to try to ask questions. I will also formulate discussion with you during the session by directly interacting with you for this EuroPCR session. So, thank you very much, and have an enjoyable lunch and Angio-FFR session.
So I guess the first step, to know about the technology is to build up what is the clinical evidence behind, And I will invite Jos Damon from Rotterdam, so that will talk us about the clinical evidence that is going behind.
Thank you, Salvatore, for the kind introduction. So it's a pleasure to welcome you all today on this session on angiography-based physiology, with a lot of focus, obviously, on the CAS medical platform and VFFR. But what we wanted to do in the first 5 minutes is to depict a little bit the clinical evidence that is currently available. These are my disclosures. So as most of you have seen over the past decade, there are now at present 4 commercially available software platforms available, allowing you to computate online angiography-based physiology. And each of these different platforms have been validated in a series of validation trials, and they actually all showed the same thing, namely that the diagnostic accuracy of these technologies with FFR, pressure wire-based, as a reference is very good and comparable across each of these individual platforms. Just a little bit of background. So this is some data of the QFR studies, almost 1,000 patients in which QFR, which is the MEDIS technology, was validated against a conventional pressure wire-based physiology system, concluding that the correlation coefficient was 0.8 with a mean difference, or so a bias of only 0.01. So that attests to the concept of angio-based physiology, in this case with a competing technology. Another type of technology is the CATwork software, which you may have seen. Similar results, very good correlation to pressure wire-based physiology, small bias, and also good diagnostic accuracy with the area under the curve of 0.94. Obviously, the interest of today will be in the CAS platform with the VFFR index. So this is the index developed by Pi Medical, validated initially in Rotterdam, later on in the phase 2 trial, an international study globally, actually from sites from New York, Japan, in which we validated in the core lab VFFR with pressure wire-based FFR again as a reference, and were able to conclude that again also with this index, angiography-based physiology is feasible and highly accurate in detecting significant lesions as defined by the gold standard being the pressure wire-based physiology tool. Again, mean bias 0.008 if you analyze this in a core lab. But importantly, this technology is not meant for the core lab. This technology is meant to be used in routine practice. And if we compare the accuracy of VFFR as computed by the core lab versus the value computed in the individual sites, we were able to conclude that the diagnostic accuracy was very good and comparable between both ways of analyzing, both in the core lab as well as on site. So there's a lot of impact of these trials. Just to show you that it's nice that we got the second position of best cited paper in neurointervention for the FAST-1 initial validation trial. But now also this year, tomorrow at PCR, we were awarded for the best cited paper with the FAST-2 study, just illustrating that there's a lot of interest and focus on these technologies. The FAST study pipeline hasn't stopped after FAST 1 and 2. We validated the concept as compared to OCT, and importantly, we're looking at outcome data. And this is the first outcome trial with angio-based physiology that has been published 2 years ago, called the FAVOR-3 China trial with the QFR technology, actually illustrating that if you compare a image-guided treatment strategy in which you randomize patients either to angio-guided procedure versus a QFR-guided procedure, you are able to significantly decrease event rates at 1 year. And even more important, a QFR-guided PCI was associated with less stents and shorter procedure time. So just again attesting to the concept of physiology-guided PCI in general. These were the 2-year results of the FAVOR-3 China trial that were very consistent and up to 2 years. Then obviously things didn't stop after this FAVOR-3 China trial, with the FAST-3 trial being on the way. So this is an international multi-center randomized controlled non-inferiority trial we're running in Europe across six countries, 40 sites, in which we randomized 2,228 patients to either a VFFR guided treatment strategy for intermediate coronary artery lesions versus a gold standard FFR guided revascularization, with a non-inferiority primary endpoint being a composite of all-cause death, any MI or any revasc at 1 year post-randomization. So the trial is now well on the way. We have enrolled 900 patients as of today, and we hope to be able to end enrollment somewhere by the end of this year. And for those of you who think this trial by itself, on top of FAVOR-3, will not be sufficient yet to change guidelines, there's a wealth of outcome trials on the way now, demonstrating the concept of each of these individual angiography-based indices in different areas across the globe, as well as with different study designs, but all aiming to show the either superiority or non-inferiority of angiography-based physiology as compared to standard of care with angio-based or FFR-based treatment strategies. So with that, I would like to conclude and allow you to learn more about the technology from a practical perspective. Thank you.
Thanks, Joss. So this is a very nice introduction about the technology. You have seen that there is actually a clinical evidence. There is also a very good plan for the future with many trials, so comparing this technology versus FFR. But we are interventional cardiologists, so we get used to see cases, and that is the reason why. So I will invite Alessandra Scoccia, also from Rotterdam, to have a look deeper to this technology, and also to have a look at one patient who may be a patient that we have in our cath lab.
So Alessandra, just before you start, let me just kick off a little bit of discussion with Joost. So one of the critiques of angio-based FFR right now is that it's not being validated in all the subgroups, right? Does it work in a bifurcation lesion? What happens in patients with low EFs? What if there's scar? How do you answer that? What do we know, and what's available in the literature or in the data to comment on those?
So yeah, this is a very good comment. Where we initially validated the technologies in a single center approach in Rotterdam, we did a fast extend trial in which we validated angio-FFR, VFFR versus FFR in almost 300 patients. And we were able to look into subgroups with patients with diffuse disease, bifurcation lesions, calcified lesions, and we were able to conclude that the diagnostic accuracy of VFFR is very consistent among each of these individual subgroups. Does that cover all of the clinical indications? No. So we know that this technology is likely not suitable for patients with osteal lesions. The technology has not been properly validated in a STEMI setting, and perhaps the most critical issue with the concept of angio-based physiology in general is the fact that you need two decent orthogonal angiographic projections, as Alessandra will show you in a second, without significant foreshortening or overlap. If you do have that, yeah, then obviously the technology is not the best to be used in a particular setting in which that is the case.
Okay.
Thank you, Salvatore, and good morning, everybody. Thank you for joining this session. My name is Alessandra Scoccia. I am a cardiologist and PhD candidate at the Erasmus Medical Center. These are my disclosure.
I guess that we are seeing the other computer, so maybe you may switch from one laptop to the other.
Yes, you are right.
Maybe someone from the technical team may help us.
Because
In the meanwhile, so I will introduce you also the two scanners that we have today. So we have Nicola Ryan and Marcel Alkbach, specifically from Ireland and Germany. So they will help us also to understand which is the value of this technology. Is someone available from the technical team?
I think they solved the problem.
They solved. Okay.
So
It's there already.
Yeah.
Thank you. Perfect.
just before presenting the clinical case, I would like to give you a short overview about what is VFFR, about the CAS software, and which are the clinical scenarios in which VFFR has been validated. So, VFFR is a software to derived FFR based on a 3D QCA. It requires two angiographic projections in order to create a 3D reconstruction of the vessel. And it also used a computational fluid dynamic approach based on the simplified Navier-Stokes equation in order to compute the pressure drop along the vessel. And this is the CAS software interface. As mentioned before, we need two angiographic projections at least 30 degrees apart, one from the other, at 15 frames per second. The aortic blood pressure is a boundary input condition into the CAS software, whereas the optimal end diastolic frame as well as the contour detection is automatically performed by the software. This is the output that you will receive from the software, but we will go in details to see this in a moment. The second question is when to use VFFR. So VFFR has been validated in a wide spectrum of clinical scenario, in particular in intermediate coronary lesion in patients with stable coronary artery disease, as well as non-ST segment elevation MI. It has been validated in multivessel disease, in stent restenosis, and non-grafted lesion in patients with previous CABG. So if a patient has a lima on a LAD and in an intermediate lesion in the RCA, that's perfectly fine. It's not recommended to use VFFR in case of ortho-ostial lesion with the diameter stenosis more than 50%, in case of severe tortuosity, overlap, or foreshortening, in case of hemodynamic instability of the patient or lesion with TIMI flow below than 3 or presence of thrombus in the lesion, as well as in lesion located in or supplied by a bypass graft. And finally, there are a couple of clinical scenarios which are still under investigation, and we hopefully we will have the data soon. So in non-culprit lesion in patient with ST segment elevation MI, as well as in patient with cardiac allograft transplantation, and finally the use of all this software in side branch bifurcation. VFFR has not been validated just in the pre-PCI setting, but also in the post-PCI setting, and recent development of the software will allow to perform a virtual stenting, but again, we will have a closer look to this tool in a moment. So now I will move to the clinical case. We have a 67-year-old gentleman who was referred to our cath lab for stable angina as risk factors, just diabetes and hypercholesterolemia, and he performed a cardiac CT which showed significant stenosis. That was his medical therapy, and here the vital sign. Looking at the EKG, we have a patient with a sinus rhythm around 80 beats per minute, normal atrioventricular conduction, absence of curve wave, and I would say diffuse abnormalities of the repolarization. Here, the echo, we can see a mild left ventricle hypertrophy with a preserved left ventricle ejection fraction and non-valvular disease. And this is what we found when at the angiogram. So we have an intermediate lesion in the mid-LAD in the context of probably diffuse disease. We have a focal lesion in the distal LCX, and in the right coronary artery, we can see a focal lesion in the distal RCA. So, my question for you is what to do next? How would you proceed?
My microphone, yes, is working. So I guess it's a very interesting case, no? And it is a case that we usually face in our cath lab, no? Because sometimes the patient reach our lab, so without any stress test, SPECT, without anything, no? And we face a situation where we have 3 vessels, 3 stenosis, some looks moderate, some severe, so we don't know what to do. And that is the reason why, so I would like to ask our discussant, so what do you do actually in your practice? So when you have this patient, do you think that the angio is enough? Or we need something more like FFR? Or you take out the patient from the lab and then you refer for a stress test?
So, excuse me. So I think this is a really nice case. We've got 3 intermediate lesions. We've got a patient with a good indication. They've got stable angina. They're on good medical therapy. We're treating them to improve their symptoms, but we don't have an obvious culprit on the angiogram. Sometimes it's very clear on the angiogram, but here we've got 3 intermediate lesions, and we know that physiology will reclassify a significant proportion of these lesions. So I think we need some more assessment, and I think we need a physiological assessment essentially of the mid-LAD, the mid to distal circ, and particularly the distal right with the PDA, that bifurcation there. So that's what I do.
Okay, so we agree that we need something more like physiology, no? And maybe Marcel, that's it for you. So now we are going to do physiology, no? And we have 2 different options. On one side we have wire-based FFR, on the other side angio-based FFR. So could you tell us a little bit about the advantages and disadvantages of each one of these 2 options?
Yeah, I think this is a good example to show one advantage. I mean, with the VFFR, you can analyze all the stenosis in a short time without changing guide catheters and so on. And if you use the wire, which I do in these cases, so I would interrogate 3 vessels with a wire also. That takes time. You need a second guide catheter. And especially in challenging anatomies, when it's not easy to wire, then it can be a special challenge, and then VFFR can have additional benefit.
Is there also an issue, I would say, with the cost, no? Because with the wire, you have to open a new device, so you add cost to your procedure, and that is something that maybe your hospitals are like. And then, I mean, I'm curious, I mean, you guys, you use a lot of this angio-based FFR, so what about the technical setting that you have in your lab? So, for example, we have this case, so you decide then you do the angio-based FFR, so you do by yourself, so you have a dedicated nurse, so who is helping you. So, what, for example, also about you, Jost, then we may go over here.
Well, so talking about the technical aspects of the system, this is software-based platform, right? So you need a connection between your DICOM providing tool, which is typically the X-ray system from whatever kind of brand you may have available, and you need to be able to transfer the DICOM images to the software platform, which is typically seamless. This typically works very well and allows you to do online instantaneous VFFR assessment within just a time period of 1 to 2 minutes. So that's approximately the time you need to do the computation. That said, you need to integrate the technology in your lab. You need to have somebody who does the clicking and the tracing. In our lab, there are typical technicians who do that. But also, in case you don't have technicians, it's good to know that due to the collaboration between Biomedical and Siemens, the software is now fully integrated in the new Siemens Icono equipment. So which allows everybody who is operating the angio equipment to allow you to do instantaneous computation of the VFFR with contour tracing with just a couple of clicks and correction if needed. So that's I think in a nutshell how the technology works.
What do you mean with the integration? What does it mean?
So at present, the software is a piece of software that needs to be installed on a standalone or integrated computer somewhere in the lab. That can be a mobile laptop, that can be a computer that is installed in the room of the technician, but it's separate from the angio system, being either a Siemens or GE or Philips or whatever kind of system. With the QuantWeb VFFR, now you can get the software immediately within the Siemens equipment, so there's no longer a need for a separate computer or laptop to be able to do the computation.
Okay. Is there any question from the audience? Or maybe you...
Right, so I was going to ask, is there any questions from the audience? Feel free to, here's a question. Please stand up, introduce yourself and...
Just to technically, you finish your assessment during the patient is in the cath lab on the table. So we can go on with PCI or anything?
Absolutely.
Okay.
No. I think that this is the big advantage, right? I mean, you do your angio just with diagnostic catheters, and if you have a nurse or a technician in the lab, they can do the computation of the angio-based physiology instantaneously, whereas you continue with making an angio of the second vessel, etc. So that's one big advantage of the technology. So there's no need to exchange the guiding catheters. There's no need to pull out and prepare pressure wires, and once you have this integrated into your workflow in the cath lab, which is obviously a challenge in some sites, but definitely technically feasible, then you can save a lot of time.
So another thing that we've not really talked about yet in terms of advantages, you don't have to switch to a guide and you don't need to heparinize, right?
Yeah.
That is the major advantage. It is directly linked to your diagnostic angiography. So you eliminate all of the risk related to heparinization and you eliminate the potential discomfort and the fitting of the guiding catheter. In the United States, where 40% of diagnostic angiograms are performed by diagnostic angiographers who don't have clinical privileges to perform PCI, this has a profound impact. Yep. Right now, what happens in those cases is a diagnostic cardiologist will perform a diagnostic angiogram, and if there's an intermediate lesion, they then either have to wait for the interventionalist to come and put the wire in, which obviously is a huge waste of time and resource, or that patient has to be referred out, have another test, non-invasive stress test, CT-FFR, or come back to the cath lab now for an invasive procedure, only, for example, for it to be negative. So this has sort of implications for workflow in different geographies that are different for different clinical scenarios.
Could I ask a technical question, please, if I may? Let's say you're doing this angiogram, and you notice that upon your catheter engagement, there's a blood pressure dampening. Does it affect your measurements, or the validity of your measurements, or it has nothing to do with it?
Jos, you want to take the blood pressure question?
Yeah, so in order for the system to be able to do its computational fluid dynamical assessment, you need an input boundary condition. So in order to estimate what the flow and the pressure is across the lesion, you need to have a proper input blood pressure. So with respect to the dampening of the aortic pressure waveform, so that obviously is a no-go. You need a proper undampened aortic pressure. So that is prerequisite number one. That, by the way, is exactly the same with a pressure wire-based assessment. A dampened pressure waveform is simply no good. And second, osteal lesions are which may cause the dampening of the pressure waveform, is at present a exclusion criterion for using any of these angiography-based technologies. Simply because of this reason, plus of the fact that the tracing of the osteum might be difficult and likely jeopardizing a proper physiological assessment.
Nicola, one of the questions that came up is whether we can use a 4 French or 5 French diagnostic catheter.
You can't use 4, sure you can't. As far as I'm aware, you need 5 French, but I'm open to correction.
So, to the best of my understanding, it doesn't matter.
Exactly.
Right? All you need to do is opacify the vessel to make sure you have a frame rate that's above 10.5 so you can capture the angiogram and have 2 orthogonal views that are less than 30 degrees away from each other. As we go through the case, there are a couple of technical aspects to this that are very important. Having a zoomed out, non-penning angiogram that encompasses the entire target vessel is really critically important. As you work through the workflow, if you haven't taken appropriate angiograms, the PI system will not allow you to make measurements. And that's to reduce the amount of error. The nice thing is, as you use the technology more often, you become used to the fact that if you're 29 degrees away, you won't be able to perform the measurement. So you sort of train your angiography to become a better angiographer along the way.
Yeah, I will add just 2 tips. One is about the nitrates, so you have to administer nitrates before, so that is very important. And second, so don't move your table. So once we have the angio, as I said, use the zoom so wider as you can, but don't move the table because otherwise so the image will be distorted. I guess it is the right moment to look how easy it is. So Alessandra, you may show us the solution of this case.
Can I ask a question, please?
We may switch it to the other computer.
Well, we'll take your
yeah.
question right after this.
Sure.
In fact, why don't we take it now while she just prepares?
Yeah.
Go ahead.
Okay, thank you. It's regarding, imagine I'm sitting in outpatient, the patient is coming with stable angina situation. What's the advantage of coronary angiography FFR over the CT FFR, and how they both are correlated? And why to choose one over the other? Of course, the advantage with CT FFR is you can have non-invasive or less invasive option providing you the same information as the coronary angiography FFR would be providing. So what's your take on that, please? Thank you.
Salvatore, you want to take this?
Yeah, I will ask you, how many of you have access to CT FFR? So very few. So I guess that the answer is how easy it is to access to one technology or the other. I guess that if you have one of them, so it's fine, because at least you may end up from the problem to have the patient without knowing what to do. But so if you don't have the access to CT FFR, because you have to send the images out from the hospital, so easy to have the software there, and then so to make either the angio-based FFR or in the worst case to perform an FFR. But then, so I will go with the software, because you will see how it is. So Alessandra, you may drive us through the measurement.
Absolutely. So we believe the best way to really show how the software works and which are like the tip and tricks.
May you use the microphone, because maybe the...
Yes, sorry. To show the tip and tricks and which are the most important feature and for performing a VFFR analysis is to really show you how to do it. And so this is the CAS software. You basically have to drag the 2 images you want to analyze into the system. And first of all, here, as mentioned before, the software automatically detected the optimal end diastolic frame, which is represented by this green and white frame. So you can, as you can see, you can play your angiogram, and then you can decide which optimal end diastolic frame to use. And the same for the other projection. The first question and the first tip is where to start the analysis. the analysis has to be started as proximal as possible. It means that in case of RCA, this is not a problem because we will start the ostial RCA, but in case of lesion in the proximal LCX, we have to, as well as for the LAD, we have to start in the left main. Okay, so I will start my analysis here, and here I will trace, and I will stop. The second important point is where to finish the analysis. This is a kind of critical question. And again, there are a few tips and tricks, like it's first of all suggested not to finish the analysis in a bifurcation or in a disease segment, because of course the distal vessel reference is taken into account when VFFR is computed. And third, just finish the analysis in a vessel with a diameter over 2 millimeters. I mean, in a vessel that you would consider to stent. Because otherwise, if we finish the analysis in a very small vessel, of course, maybe the VFFR value will be lower, but we couldn't really do nothing about it. So 2 millimeter is the kind of threshold that we used. And we will do the same in the other projection. So we can play the angiogram. We can decide which optimal frame to use. And again, we will start the tracing from the left main, that in this case is very, very short. And we will finish the analysis more or less in the same location of the previous one. As you can see here, you have the possibility of make correction, because if you look here, in this case, there was just a little less opacization of the proximal segment, so you can correct the automatic contour detection by clicking on the segment and just double click, and the software again will correct automatically. The other question will probably be, what is this red dot? This is called common image point, and it has to be in the same location in both angiographic projection. So it doesn't matter if it is in the stenosis or at a side branch location. It can be wherever you want, as long as you are sure that is in the same point in both angiographic projection, because this is used for the 3D reconstruction of the vessel. So in this case, I think it's fine to have it into the stenosis. We could have also used this obtuse marginal branch as common imaging point, but it's fine. And then, as mentioned before, the aortic pressure is an inlet boundary condition. So we saw for this patient that the blood pressure was 109/71, and then you will simply press calculate VFFR. And this is the output that you will receive. As you can see here, this is the VFFR value with the pressure drop, but we have also a lot of other interesting information. Here you have the vessel diameter, and here we can see that we have ended the analysis in a with a distal vessel diameter of around 3.5. And here you can see the vessel diameter at the point of the stenosis. And while in the box below, we can see the pressure drop. So in this case, we can really see that this is a focal lesion. You can see that the pressure drop is, the pressure is conserved here, and at the level of the location, we have this pressure drop, which then remains constant after the stenosis itself. So this is the first example. I think we can have a look also to the other vessel. And yes.
Here to do our colleagues. So you see that in one shot, so we got two kind of information. On one side, we have the value of the FFR, so which is there, but also we have the pullback of the FFR. So you see Yeah, on the bottom, so you see how the pullback was look like. So, and that is something which is becoming more and more important nowadays, because you know that we can recognize if there is a focal lesion, so that you may easily fix by a stent implantation, or if there is a diffuse disease. And we may also, playing with this screen, you may also plan your PCI, so which the stent should go, landing zone, etc., etc. So in one shot, you have FFR, and also the pullback for planning your PCI. We may go maybe to the rest of the vessel.
Yes, I will quickly show the other case. Maybe we can, here, we can go to RCA.
So in the meantime, a very important question came up with regards to the technical implementation of this into your cath lab. So I think that's a very important one. So there are two ways to basically get the DICOM images that I'm aware of. Yeah, please panel chime in. One is use a DICOM node. That is the X-ray system directly pushes the X-ray images, either the ones that you select or all of them, directly to the Angio-FFR system. Okay, so that's the fastest way. The second way, which is a little bit more of a turnaround, is actually that your DICOM goes to your PAC system. After you've got all your angiograms into the PAC system, you can then push them from your PAC system direct into the Angio-FFR system. And so the DICOM node that is within your big metal, GE, Siemens, whoever you're going to be using, they will activate the DICOM node to push it directly onto your Angio-FFR system. It requires an individual IP address. Those IP addresses need to communicate. Practically, you need to have this integrated through your hospital IT system. So it's going to take a small amount of time, but it certainly requires their input in order to be allowed to get it. It took us a little bit of while to get it started. It took us probably a couple of months to get all the IT security issues and so forth sorted out. But once it was activated, it's been seamless.
Yeah. So, Alessandra, are you going to make the right coronary artery?
Yes.
So,
no.
which was the value of the circumflex actually? Because I didn't.
0.91.
91.
So
okay.
it was, the cutoff for VFFR is as per FFR 0.80. Here we can see a very nice case. We are analyzing the RCA, and again we can see the diameter of the vessel, but what is interesting here is again that we have a distal focal but really tight and significant lesion, which bring the pressure from 0.95 to 0.77. So this is short but tight lesion is a physiological significant lesion. And I would like to show you in this context the residual VFFR or virtual stenting, like the tools I was mentioning at the beginning of the presentation. And this is a tool which allows with using the pre-PCI angiogram to perform a virtual simulation of a PCI, and will give you also the functional gaining after a PCI. So by placing a stent of around 14 millimeters, so a very short stent, we will have a VFFR gain from 0.77 to 0.91. Of course, we can change this and see how everything will improve if we place a longer stent, and which will be the gain also in this case. But the software automatically suggests you which is the, let's say, best length in order to have the best gain.
It's interesting also to see that there is a sort of co-registration, no, between the FFR, which is below, and then you may scroll on the FFR, and you are totally sure where you are located in the vessel. So in case you have, for example, different stenosis, so a sort of diffuse disease with different stenosis going on the right coronary artery, you may be sure which is the lesion, so most responsible of this value of FFR. So you may simulate the treatment of the distal lesion, both lesions, or, for example, the the proximal lesion because you may scroll and you know where the lesion is located and from where you have to implant the stent. So the circumflex was negative. The right coronary artery looks positive. So let's have a look of the
quick
LAD.
look to the LAD.
So questions from the audience in the meantime? Will we pull up a question? Please go ahead.
I have a question about the distality of the measure. We know that when we measure FFR with a pressure guide wire, the more distal we are, the lower the FFR we get, especially when we do a good extubation cannulation from the osteum. Do we have the same thing with this kind of measuring?
Marcel?
Yes, actually, as you said, I mean, the more distal you get, the lower is the pressure. And I mean, this is the true pressure. And I guess you see this phenomenon with both techniques.
So we have to take a more longer segment to have a more precise evaluation of the virtual FFR?
Not necessarily. I mean, we have seen that here, that the part of the vessel you need distal from the stenosis doesn't have to be very wide. Yeah, in the first example, we have seen that. And so you don't have to go to the very distal vessel to do the analysis.
The most important thing was actually what Alessandra said, so avoid a small vessel, less than 2 millimeters, and avoid also to land with bifurcation. So if you have a bifurcation, so please do it before. No? And I guess that with these two tips, so you know that you have to avoid just these two things. So for the rest, so the measurement is reliable.
If I can add one more point, and I think, I mean, the question is also how much are you really interested in a very distal FFR? So I think from a clinical point of view, if you have a proximal or mid stenosis and you're actually not interested so much what the very distal vessel does, so maybe you are, it's okay if you have a FFR above 1.8 in the major vessel part, but if there is some ischemia very in the distal part, it's clinically not so relevant. So I would also not suggest to make an FFR recording in the very distal vessel and then treat the whole vessel just to have no ischemia in the very end. I mean, it's surely debatable.
And to the gentleman who asked the question about CT-FFR, this is actually one of the advantages because the CT-FFR, you can't choose where the vessel you'd like to do the assessment. In general, from a technical point of view, you should begin and end your angio-FFR measurement the same place that you would distally put the pressure transducer to perform an wire-based FFR. So you will get an assessment of that length. In general, we do the target vessel, the sort of proximal 2/3, and we avoid putting the wire into the microcirculation. So if you want to stay a little bit more proximal, to have a lesion and vessel specific assessment.
And here the result of LAD. This is, as you can see, the VFFR is 0.87, so it's VFFR negative, but what is, I think, also very interesting is to see how is the pressure drop along this vessel. And as you can see, it's kind of progressive. There are no focal lesions, so this is a diffuse disease lesion, which is actually not physiological significant. So probably medical therapy for this lesion is the best treatment we can give to our patient.
So actually we end up, so it was at the beginning a 3-vessel disease patients. So we were not knowing about which vessel so should be treated. And we end up that the LAD, so there is a diffuse disease, so there is the FFR is negative. So this case will be optimal the medical treatment. The right coronary artery was positive and the circumflex was negative. So from 3 vessels, so we end up with 1. You have seen actually how easy it was, and so we may treat our patient. I guess that we may have time maybe for a couple of questions. I don't know if you have something in the chat or, yeah. Go here with the microphone so that your colleagues may hear you.
So I have one question here. We know the most important is calculate the pressure drop. So for the pressure drop with a boundary condition, And from the procedure, I saw we input the pressure value. And do we need like the flow value, for example, from the...
No.
No? So...
You don't need anything other than the angiogram in two views that are 30-degree apart that outline the lesion and the blood pressure. That's it.
Okay. But we look at the pressure drop calculation. The pressure input not enough. Yes. We need the flow information, I guess.
No. This is a validated technique in multiple studies with very high diagnostic accuracy based only on the blood pressure and the two angiograms.
Okay. Thank you.
Yeah, very last question here from the first row.
Yes. So you need a special connection for the blood pressure measurements?
No.
Or is it the
You
same?
enter it manually. Whatever is on the Mac lab.
Yeah, and you feed it to the system that the pressure is so and so.
You only need to record so the blood pressure when you do the angio, and then you feel manually so on the console.
Because I've seen some systems just by the angio. You get your.
You may do it, I guess, if it is integrated, so it goes directly. But otherwise, so you just need to record because otherwise, so you feel have not done the recording, so you don't know what was the pressure at the time of the angio. And then once you have it, so it's manually typing there, and that's it.
You are correct. There are multiple systems. One which requires a special connection of the blood pressure to improve the fidelity. Some of which don't require blood pressure, but they're all validated in slightly different ways. This specific system is a manual entry of the blood pressure at the time of your recording.
So I guess the time is running, so I would like us to summarize the key learning points to me. So I think that the most important thing that you have to remember is that how easy it is to take the measurement. So you have seen that in the main while that we were discussing, Alessandra took the measurement in a couple of minutes for the 3 vessels, and you only need so to administer nitrate, to record the blood pressure, and to make the QCA by using a 2 angio 30 degrees apart each other. So that is the learning point for today. So I would like to thank all the speakers, Ziad, and also our discussant, you, who have been today with us, and also, of course, Siemens and G, who help us with this symposium. Thank you very much, and enjoy the rest of the day.